السلام عليكم ورحمة الله تعالى وبركاته. كل سنة وأنتم طيبين. My presentation today, how to deal with the resistance of type 1 diabetic patient not too fast. My objective of this presentation to discuss important physiological aspects of Ramadan, identify people who exempted from fasting, and then illustrate problems with the fasting, identify the risk stratification, and advise to patients with moderate high risk to fast safely. What's the Ramadan? Ramadan is holy month of fasting. It's 9 months of a lunar calendar lasting 29 to 30 days. And Ramadan is one of the 5 pillars of Islam. And there is a religious obligation on a healthy adult Muslim. Muslim fast from eating, drinking, smoking, and all vices from dawn to sunset. And there are 2 meals, one of the suhoor, which is meal before dawn, and iftar meal after the sunset. We have to understand about physiological aspects of fasting. Insulin secretion, which promote the surge of glucose in the liver, muscle, and glycogen, which is stimulated by the food in healthy individuals. During fasting, circulating glucose level tend to be fall because there is decrease in food intake, and that's leading to decreased secretion of insulin. On the other hand, levels of counter-regulatory hormone, glucagon, catecholamine rise, stimulating the breakdown of glycogen. At the same time, gluconeogenesis is augmented. As fasting becomes protracted from than several hours, glycogen stores become depleted, and low level of circulating insulin allow to increase free fatty acid. The oxidation of these free fatty acids generate ketones that can be used as a fuel in muscles, cardiac and skeletal, liver, kidney, adipose to spare glucose to be continued utilization by the brain and erythrocyte. Fortunately, in healthy people, these conditions going smoothly by delicate balance between circulating levels of insulin and counter-regulatory hormone to maintain blood glucose in the liver. Patients with diabetes, usually they have defect in hormone action and secretion. Glucagon secretion may fail to increase appropriately in response to hypoglycemia. Also, epinephrine secretion is also defective in some patients because of combination of autonomic neuropathy and defects associated with recurrent hypoglycemia. Patients with type 1 diabetes with severe insulin deficiency, during prolonged fasting, the absence of adequate insulin lead to excessive glycogen breakdown, increased gluconeogenesis, ketogenesis leading to hyperglycemia and ketoacidosis. The people who exempted from fasting is prepubertal children and adolescents, menstruating women and women with postpartum bleeding, pregnancy and breastfeeding, those with mental illness, traveler elderly, and the most people for us, those with acute and chronic illness. Diabetes mellitus, one of the chronic illness exempted from fasting. Why? Because there are many risks if insulin is withheld. Hyperglycemia, DKA, hyperosmolar hyperglycemic state, dehydration, venous thrombosis. And even if we give insulin with or without dose adjustment, hypoglycemia will be a problem. So warning signs of these conditions, either hyper, DKA, should be given along with the instruction for patient to break their fast and seek medical attention if symptoms occur. When we come to this presentation, how to deal with patients who resist not to fast. So it's worth to re-emphasize that fasting for patients with diabetes represents an important personal decision that should be made in light of guidelines for religious exemption. Also, after careful consideration of the associated risks on consultation with healthcare provider. Most often, the medical recommendation will be not to undertake fasting. Patients who insist on fasting need to be aware of the associated risks of fasting experience and technique to decrease this risk. Patients may be at higher or lower risk for fasting-related complication depending on the number and extent of their risk factor. Diabetes management during Ramadan, pre-Ramadan diabetes management planning, including risk stratification, is very important to know where the people at which level of the risk stratification. Monitoring glycemic control while fasting in Ramadan. pre-Ramadan diabetes management planning, healthcare provider assessment recommended 1 to 3 months prior to Ramadan for those intending to fast. Risk stratification, review of positive and adverse experience from previous fasting, formulate individualized treatment plan. When we come to this figure here, the key component of Ramadan focus education program start by risk stratification, blood glucose monitoring, fluid and dietary advice, exercise advice, medication adjustment, and when to break their fast. Risk stratification. First thing, we start with very high risk. Those people must not fast, must not fast. Those with body control type 1, hemoglobin A1C more than 9, severe hypoglycemia within 3 months and recurrent hypoglycemia and hypoglycemic unawareness, ketoacidosis, hyperosmolar coma, acute illness, chronic kidney disease, and pregnancy and diabetes in those people treated with insulin. We come to the high risk, those who should not fast. But if they fast, they need medical advice. Those with moderate hyperglycemia and hemoglobin A1C between 7.5 and 9, renal insufficiency, advanced macrovascular complication, living alone and treated with insulin, ill health treatment with the drugs that may affect mentation. And those with moderate and low risk, they can fast. Also, they need medical advice, those with well-controlled diabetes. Ramadan focuses structured diabetes. The role of structured education for patients is well established in management of diabetes. This should be extended to Ramadan focused diabetes education. Many Muslims with diabetes very passionate about fasting during Ramadan, and this passion actually is golden opportunity to empower those people to look after their diabetes and better management even out of Ramadan. Raising the general awareness of Ramadan and diabetes should be strengthened harmony between medical and religious advice. So we have to be greater understanding regarding the religious and context and the perspective regarding Ramadan and active fasting, and also the potential risk and the medical option to achieve safer outcome to those people who wish to fast. Healthcare professionals should be trained to deliver a structured patient education program, which include glucose monitoring, when to stop fast, meal planning to avoid hypo, appropriate choice of meal to avoid hyperglycemia, advice on timing and intensity of exercise, and important to discuss the use of insulin and its potential risk. Several important issues deserve special attention. Individualization. There is no fit to all people. Every person moves, every person behaves in a way different from the other. So we have to concentrate in the individualization when we give the education. Frequent monitoring of blood glucose, it's needs 5 to 6 times a day. And some people like to use CGM, which is continuous glucose monitoring. Also, nutrition, they need to advise about nutrition, as many problems arise because of an appropriate diet, from overeating or insufficient sleep. And actually, nutrition advice giving to each patient according to his need and the aim to maintaining blood body mass. It's also recommended to increase fluid intake. Exercise should be avoid exercise at the hours before the sunset, and usually can encourage Salat Tarawih as a part of exercise. And don't forget, exercise can cause hypoglycemia during fasting and sometimes in poorly controlled, leading to hyperglycemia. The patient should break their fast when the blood glucose is less than 60, and also they should break their fast if less than 70, and that should happen in the few hours after start of fast. The fast should be broken if blood glucose more than 300. Patients should avoid fasting in 6 days. Insulin management during fasting. It's currently recommended to use intensive insulin therapy as the best way to treat diabetes during the Ramadan. Some patients type 1 prefer to fast at Ramadan, need to change their insulin regime immediately before, during, and a few days after this month. So the basal bolus regime is the preferred protocol of management, and it's thought to be safer and fewer episodes of hyper and hyper. Many studies which was done to show the effect of insulin glargine, which is relatively safe and effective in management of type 1. In this study, which was done on about 15 relatively well-controlled patients fasting about 18 hours who are fasting safely experienced minimal decline in mean blood glucose level with 2 episodes of mild hypoglycemia. And there is another study which showed the people who are used rapid acting insulin analog instead of regular insulin in combination with intermediate acting insulin injected twice a day lead to improvement in postprandial glycemia and was associated with fewer hypoglycemia. From my experience, I work with insulin pump therapy since 2013. I find the best one during the Ramadan is continuous subcutaneous infusion management, which is appealing alternative strategy. And this study showed the better people who are fast on the pump, improving their hemoglobin A1C comparing with the people who are not fasting Ramadan. My conclusion, patients with type 1 diabetes are at very high risk of life-threatening complication. Patients with type 1 diabetes who have a history of recurrent hypoglycemia or hypoglycemic unawareness or who are poorly controlled are at very high risk for developing severe hypoglycemia. An excessive reduction in insulin dosage in these patients to prevent hypoglycemia may place them at a risk of hyperglycemia. Patient's decision to fast should be made after ample discussion with a healthcare provider concerning the risks involved. Patients who insist on fasting should undergo pre-Ramadan assessment and receive appropriate education and instruction related to physical activity, meal planning, glucose monitoring, and dosage and timing of medication. I will give this message, which is take-home message to people who are insist to fast. Please test your blood glucose level, and it's important, and it does not break the fast. Talk to your blood doctor or diabetes team before fasting. Look for signs of hyperglycemia, hypoglycemia, and dehydration. Make sure someone you know is aware that you are fasting. Always carry your glucose tablet, glucose gel, or sugary drink in case of hypo. If you are ill, it's important that you break your fast. Thank you very much for your attention.